So can hopefully people have to see that.
Perfect, lovely.
Okay, lovely. So my name is David Redaway. I'm a clinical community dietitian. I've been a dietitian for 12 years or so now, or 12 and a half years probably. So I've been working in Torbay since 2015. I was in the community team as a home enteral feed dietitian, and then specialised in motor neuron disease, as well as the general like home visits, community hospitals, etc. So if I go on to the next one. So a opportunity working in the primary care network came about, and I was successful in getting the role as a malnutrition and frailty dietitian working in the Paynton and Brixton PCN, and I started that in July 2021. So I guess the majority of my presentation is about how that went, I suppose, how I started a service up, and how it's going and what the future is going to hold, I suppose. So I work with 3 practices: Mayfield Medical Centre, Corner Place Surgery, where I'm based today, and Old Farm Surgery. So between them, there's about 50,000 patients. As I said, it's a brand new role, so literally, starting it from scratch. And I come across, quite a few challenges in terms of to me, it's like starting 3 new jobs at once. Each GP surgery worked differently. There's obviously different people working there. Space was a problem because there's lots of new people being employed, so particularly things like people like pharmacists, social prescribers, so lots of new kind of people coming in at the same time. And also, I suppose it was trying to sell myself. Some people don't really know what a dietitian does. I guess they just think we tell people not to eat cakes and stuff. So there's that challenge again, kind of promoting my role and showing people hopefully what I can do. So I attended a series of GP meetings, kind of promoting what I did, introducing myself. I produced a referral form with my referral criteria, which then went in the newsletter and various emails, and I believe it's on the website as well at the moment. I shadowed as many people as I could, so I didn't really have a timetable for a lot of it, so I just literally had to arrange all these things myself. And yeah, I did some presentations. I've got to write a report every couple of months with what I've been doing, basically. And I've been trying to build links with other services where there's currently little kind of dietitian input. So I've built a rapport with the drug and alcohol service because we're seeing lots of people with mental health problems, drug and alcohol problems, and obviously working with a service who know these people well, I thought was a really good opportunity. So that's been quite good. I've also been working closely with pharmacists, looking at supplement prescribing, and there's a lot of inappropriate prescribing in the hospital of people just writing Ensure, for example, with no kind of concept of how many, how often, which type, and those kind of things. So almost like trying to find where I'd fit best and not duplicating services, basically, so offering something additional. This is I think this is on the website for the PCN. So I put together my referral criteria, basically. So I won't go through all of that for time issues. But basically, looking at people who are malnourished and frail, so particularly underweight, various long-term conditions, things like pressure sores, supplement reviews, all sorts of things really. So I kind of started off with an idea that I'd be seeing people aged over 65 for malnutrition and frailty, but it soon kind of developed into, really reducing my kind of criteria a bit, I suppose, or sorry, relaxing the criteria a bit to kind of what the surgeries wanted. So actually it's turned into anyone who's malnourished, who's an adult, basically. I also do some IBS, because I have a background in FODMAPs and irritable bowel syndrome and dietary interventions. So I've kind of not doing the FODMAPs because there's already a service there for that, but I'm picking up first line IBS, so seeing people and giving first line advice, which in some cases has meant they haven't needed to go on for further investigations or go on to more complex interventions. So that's good. So some of the benefits of what I've been doing. So the main aim, I guess, is we're seeing more complex people in their own home. So it's trying to prevent admissions, so protecting the acute services, which are often very, very stretched. As I said, it's not duplicating service which is already there, it's complementing them. So kind of seeing patients who might not have otherwise been seen. I can see people much more quickly. So currently the community dietitian waiting list goes into, you know, maybe even a month for very urgent ones and 3 months or more for non-urgent. So I can see people if they're very urgent within, you know, so in the past I've seen some the same day sometimes. So it's that response time which can be very, very important. I found that I've also kind of acted as like a link. So there's many different, you know, dietitian services, ways of referring, you know, GPs, you can't necessarily expect them to know all the intricacies of that. So I've been able to kind of link in, so people get reviewed more quickly into the, you know, maybe referred on to the right person. There was 1 week, for example, where I had 4 oncology referrals needing urgent reviews. So I don't see them because the Macmillan service is already there, but I was able to liaise with the Macmillan dietitians and get those people seen ASAP, whereas they might have been, you know, dragging on a bit if, you know, the GPs or whoever didn't know where to refer or who to speak to. So although I didn't assess them myself, it actually ended up being a positive because I got them seen soon. I've often been, you know, refer into other services, like I said, particularly paediatrics, gastro. So again, people get seen hopefully quicker if they're sent to the right place. I'm working particularly with the social prescribers. So one of the things I've noticed working this role is there's a lot of people who are on low incomes, who are struggling with their mental health, maybe, like I said, drug and alcohol before. So linking in with a team like the social prescribers has been really valuable. Also just promoting the role of the dietitian, becoming more visible. So, you know, historically dietitians are quite a small profession, and you hear the argument time and time again that people don't know who the dietitians are, what they do. So it's just really promoting that role. Potentially saving GP time. I know there's some debate about whether that has actually happened in these PCN roles, but certainly patient satisfaction experience is something that is, you know, people have commented that, you know, that's definitely been an improvement. Just a quick patient story, just to illustrate, you know, what difference can be made. So there was a lady who was very malnourished, had chronic leg ulcers, self-neglect, safeguarding issues, was fed by NG tube on the ward, was starting to do quite well, was discharged to a nursing home for rehab. Again, one of my community colleagues was assessing her, and she was actually, you know, picking up quite well. But then she self-discharged against advice, but she was deemed to have capacity. So she ended up going home. There was no package of care. Things like her medications were not in place. You know, nothing was in place really, and she wasn't able to do anything for herself. So I had a handover from the community dietitian. I was able to make the GP practice aware that this vulnerable lady was home. I spoke with the social worker. Again, they were trying to fast track a package of care. I spoke with the district nurses that would be going in to check her wound dressings, and I arranged a visit the next day with one of the district nurses. I spoke with the pharmacist to get her medications sorted out, including some nutritional supplements which were specifically for wound healing, and also sorted out an easier way for the carers to order it because the patient wasn't able to herself. And subsequently, a package of care was put in place. She was eating better. You know, and I think in this case, obviously you can prove it, but I'm pretty certain that, you know, working as a team prevented this person being admitted straight away again. So I think that's a good example of just with all the people I know and the links I can make and the speed of my actions, hopefully in this case prevented that lady from going back into hospital and prevented a crisis basically. So at the moment, so I've had 433 referrals across the PCN. So I'm having to work in a different way as well. So I realise I can't keep, reviewing patients as I may have done in my old job. So I'm looking more at safety netting, so the definite clear plan in place, liaising with other professionals, so particularly maybe the pharmacists who might be reviewing the supplements, so they know, when someone should be on them and maybe when to consider stopping. I'm a member of, several different primary care network dietitian groups. So we have lots of meetings, we share information, resources and experiences, because lots of people in the same position of setting up this new service. I'm currently doing a master's module for a first contact practitioner. So I've done 2 days of that so far, and that runs until next summer, approximately a couple of days a month. So the idea is that not only by assessing people from a nutritional point of view for frailty, but I'm also maybe looking for red flags. Obviously, we do that anyway, but I'll be doing more of that. Maybe some simple kind of assessments. So knowing how to refer on, knowing how how to highlight certain things, maybe requesting specific bloods, those kind of things. So kind of integrating more into the PCN model, I suppose. So yeah, so that's an overview of my role, and we've gone through a lot in a short space of time, but yeah, that's kind of what I did and where I am. So
Super, that's great, David. Sounds like an absolutely brilliant role. Have we got any questions for David? Anyone want to pop their hand up or pop anything in the chat?
Shall I stop sharing that?
Yeah, thanks. Any questions from anyone? I guess I was just wondering, David, obviously PCNs are more commonly employing AHPs directly. You talk brilliantly about the benefits for patients. What about as a clinician and your career development and your career yourself? What are the pros and cons potentially of working with the PCN directly?
So I'm actually employed by the trust still. So I'm kind of like I can't think of the word, but like I'm on like a 2 years comment, and actually my role has just been extended until March 24. So I think the word is subcontracted out. So in that sense, there was a lot of conversations between the PCN and my service lead, Liz Wardle, about this role. So what they felt was it's really important to keep the links. So I have supervision from my Band 7 line manager still, who's the community team leader. So I have one-to-ones with her, and obviously CPD opportunities still with them. But also because I have links to all the dietitians, it links in really well with the PCN. So in the meetings I've been attending across the country with other dietitians, there's been lots of different experiences where they've been employed directly by the PCN. They don't have these links. They don't know what services are there. There's concerns that people are kind of stepping on other services' toes and all those kind of things. So I think from my point of view, I know what services are there. I know how to link in with them to get people seen better or to direct people to the right service. And I know where I can make a difference, where there's maybe patients who are currently not being seen or not being seen soon enough. So I think that's a massive benefit, as well as kind of promoting the role of the dietitian, having like a proper streamlined role, I suppose. Some of these other dietitians have literally gone in with there's no kind of, they're literally starting from scratch, where they don't know specifically what sort of patients they're seeing. They just get given everybody. So I think the benefits of having this, clearer role and the support around there, as well as all my links, has been pretty vital, really.
Sounds great. Sounds like the best of both worlds. So
I think so.
super. I'm not seeing any more questions at the moment. So what I'll probably do is if I hand over to Sam and there's any more questions. Oh, Matt's just come in just in time. Matt, do you want to?
Sorry, have we got time?
Yeah, if it's a quick question, Matt, I know what you're like.
I think it is a quick question. David, thanks for your presentation. It sounds like a great role, but I was just wondering, that question you had around the controversy about whether there is kind of reduction in GP workload, and your thoughts on that, because from what you'd said, it seemed quite a compelling argument that there may be. So I didn't know how you felt about that, what your view on that controversy was.
So I think that was also one of the main selling points of the PCN roles. I think from my point of view, I think GPs are definitely having their time saved, because they, you know, things like supplements, for example, they don't know which supplement, how long, whatever. So if they can just send me a task, I can sort that out quite quickly. Or if, you know, they maybe try and give some basic advice around whatever it might be, you know, nausea or weight loss or whatever, but rather than that, they can just send a task to me, and they can then get on with the next patient. And similarly, you know, they don't know where to refer somebody. So a lot of what I do is actually, as well as assessing patients, is actually directing to other services or resources, or just, you know, sometimes it's just a quick 5-minute thing, which could save the GP 15 minutes or something. So I think anecdotally, I feel I'm definitely saving the GP's time. Obviously, when I need maybe to go back to them when there's other things, you know, getting in the way, because I find that we often have more time to kind of discuss things with patients, and I think that's one of the strong points, because you've developed that relationship, you find out a bit more about things, whereas GPs are very, very time pressured, and might only deal with one thing at a time. So I think I can give the patient a more holistic kind of overview and try and, you know, address things, which sometimes does mean, you know, going back to GPs and saying, well, can you consider this medication or this or that? So I guess it's two ways, but again, what they are saying is they've noticed the patient experience is improved. Whether or not it saves GP times overall is another matter, but the patient experience definitely is better.
That's great. I think patient experience is really important, isn't it? So I think that's half of it. Super. Thank you, David. I think just in the interest of time, we're going to hand over to Sam. We can always come back for any, if we've got any more time at the end, we can always have more questions at the end. So if I'm happy to hand over to Sam, that would be great.
Thank you. I'll just share my screen. Can you all see this?
Yeah, all good.
Excellent. Okay. Hello, I'm Sam Gregory. I'm a head and neck cancer speech and language therapist, and I work at Torbay Hospital in South Devon. And I'm going to talk to you about our trip to Boston in collaboration with the Swallows Head and Neck Cancer Support Group. This is something I never thought I'd ever do in my whole career, and I've been very fortunate. I only came back this week, so I'm a tiny bit jet lagged, but hopefully I can share with you what we've been up to. So I just want to tell you about our team. So I'm the clinical lead for head and neck cancer and speech and language therapy. And I'm really privileged to work with an amazing team of doctors, oncologists, surgeons, coordinators, and I'm part of what we would call our cancer support team. So this is our team. So top left, we've got Sarah. She's another speech and language therapist. We've got Debs, who's our dietitian, and we have Amy and Fahida, who are clinical nurse specialists. And any patient that's diagnosed with head and neck cancer have us as their cheerleaders, we would say, from diagnosis to discharge. So the 5 years that the patients are in our service until they're discharged, we look after them. As a speech and language therapist, it's my role to support people with their swallowing, talking, and just generally their emotional well-being as best we can as a team. When I started my role in Torbay 5 years ago, the patients, I know they had their support team, they had their doctors, they had their friends, their families, but there wasn't any local support groups that they could join to meet other people that had head and neck cancer, or their caregivers that have gone through this very long and traumatic process. So when we started, I heard about the Swallows Head and Neck Cancer Support Group, and I was really lucky to meet Chris and Sharon. Chris and Sharon are the directors of the Swallows Head and Neck Cancer Support Group. And the reason we have this group is Chris had a head and neck cancer himself. He had a tonsil cancer in 2011, and he had surgery and he had chemoradiotherapy. He was unable to eat and drink for at least a couple of years. He was dependent on a peg tube, and the treatment that he had was brutal. Chris will readily admit that. He had his cancer support team, he had his doctors, he had his family, but he didn't have anybody that had gone through what he had gone through. And so what Chris decided to do was put together the Swallows, and it's just grown from there. He initially started with a local head and neck support group in Blackpool. And as his charity has grown, the support groups are now international. They've got groups in Australia, in South Africa, in Spain, and we now have one in Torbay. There's quite a few in the UK as well. The amazing thing about the Swallows is they, as clinicians, we want to support our patients as best we can, but what Chris does is he takes the support group and sets it up for you, actually. So it was our job to identify patient leaders. So we wrote to all our patients, asked them if they were interested in supporting a local patient and caregiver support group. And some wonderful people came forward. We introduced them to Chris. Chris helped them find the venue. Chris organised, he pays for the venue. He organised all the mail shot, and we launched our meeting this year, which was fantastic. So the wonderful thing about the Swallows meetings is they happen every second Wednesday of the month at 7 p.m. So all over the UK, every single meeting will meet at the same time. We did want to launch our local meeting in 2020, but as we know, everything shut down because of COVID and went online. So Chris took the Swallows meetings online, and we took our meetings online, but we waited for patient-facing meetings to come back. So we were really lucky having the support of all of the trust. We had Liz Davenport visit our launch night, and we had other directors come. We had members of our cancer support team, but actually more importantly, we had patients and their caregivers, and we filled the room. So this is the Community Hall of Kings Tainton Community Centre, and there were people lining up out the door. It was wonderful. Chris did a short presentation about what the Swallows charity do, and we had an international speaker from Boston. We had Arthur Laurentano, who is a surgeon at Lowell General in Boston. And it was at that meeting, actually, that it was announced that one of my colleagues and I would be going to Boston. So it was a bit of a shock, but a wonderful one. But the whole point of these meetings is I've put a couple of quotes on there from what our patients would say to us is, no one will know what you're going through better than someone who's already been there. And one of the unique things that the Swallows charity provide is a 24-hour helpline, which is only answered by Sharon and Chris. So if you're a patient, Chris will talk to you, and if you're a caregiver, Sharon will talk to you. They carry the mobile with them 24 hours a day, all year long, and they even took calls while we were in Boston. And quite a lot of our patients say to us, the Swallows help them when they needed to talk in the middle of the night, and that's such a unique service to have. They don't give medical advice. They direct the patients to their clinicians if there's anything related to medical advice, but they just listen and say, yeah, I've been there. I remember what it was like. The treatment is hard, and to lose your ability to talk and communicate and eat and drink is and really for nobody to see it happening as well, because a lot of our treatment happens on the inside, is so debilitating for our patients. So this charity is just absolutely amazing. So we met, so that's Fahida there, and myself and Sharon and Chris. We went along, something else that Swallows do is international conferences. So we went to a conference in Brighton in 2019, and that's actually where we met Arthur. He's flown over to every international conference that's happened in person, and he has never missed an online patient and caregiver meeting. He is absolutely amazing. And the aim was for us to go to Boston to share what we do, to share our good practice, to learn from their good practice, to promote the Swallows charity, and to launch a group there. They don't have a patient-led group in Lowell. Something also to mention is Chris and Sharon have been awarded the Queen's Award for voluntary services. So it's an absolutely amazing charity. So we got to Boston. And we, in this picture, you've got myself and Fahida. In the middle, that's Kylie. She's a dietitian, and she's actually the head and neck cancer navigator. Next to Kylie, you have Elisa, and she's the cancer centre director, and then also Chris. We were absolutely spoilt rotten for the whole week. We spent 5 days with the team. We followed them around all week and met patients. We discussed the differences between the NHS and private healthcare, which I won't go into. But the big thing to say is any patient receiving cancer care for head and neck cancer at this cancer centre, if they do not have insurance, they still get cancer treatment. There are charities that are there to support our patients or their patients. And it's just amazing that they can access this care. So the wonderful thing about this time we had is we got to meet other professionals while we were there. So they set us up in the conference room. I met this speech therapist and had a great time. We met Arthur and worked with Arthur, and Kylie in the top right there. She is basically Fahida's counterpart. So Fahida is our clinical nurse specialist who is our patient's key worker. So anybody going through this treatment, Fahida and Amy are their go-to. They coordinate appointments, they liaise with the medical team, they signpost patients to different services, and that's exactly what Kylie does. But she didn't do it until Arthur met Fahida back in 2019 and took the model of the key worker to his cancer centre and created a job, and that's the job that Kylie does. So she's absolutely fantastic. She run around, I can't imagine how she holds everything in her head, but she knows every single patient, just like, you know, actually our nurses do. Coordinates their appointments and is a dietitian as well, so she is able to do that role. Not only were we able to see these wonderful professionals in person, but we also were able to arrange a video call between our dietitian, Debs, and Kylie, and it was lovely listening to them chat about what they do. So being a speech therapist, obviously I'm going to have to talk about something to do with speech and language therapy. So this is me with the speech therapist there, or speech language pathologist. And actually I was able to share some of our best practice. So in the UK, we are using a device, some patients that have difficulties with tongue and throat strength after their treatment. We have this device that we purchased through charitable funds that rehabilitates tongue strength using a little air-filled bulb that you squeeze, and it's based on exercise science. We set them up with a program. They do it for 6 weeks. We see them every week to modify that program, and we have really good outcomes with patients swallowing rehab. So I was able to share this with them. That's something that they don't have, but hopefully they will. We had a brilliant tour of the hospital, and we got to meet some of the team that work in radiology. So for some of our head and neck cancer patients, they would have radiotherapy. As you can see in the top right hand corner, our patients have to be in the same position every day, 5 days a week for 6 weeks. And that is what they have to have that mask fitted, they have to be secured to the bed, and the treatment is given so it's accurate. And we met with a patient who was 5 years following his treatment, and I can't imagine lying on that table, being secured to that bed 5 days a week. And when he met his radiology team, he said, when he had his mask made, this was a lovely quote. He held my hand and said, "This is going to be hard. We're going to get you through this." And he felt like he was terrified, but they were validating his terror. And I thought that's a really lovely way to put it, actually, at how supportive those teams are. And it's exactly the same here in the UK, which is just wonderful. This is some technology that they're using in the US, and they do have it in the UK. We don't have it in Torbay. It's called Thor laser therapy, which uses I've written it down so I don't get it wrong. Photobiomodulation therapy for oral mucositis. So it uses a laser LED to reduce the severity of the ulcerations that can form in your mouth when you're having head and neck cancer treatment. It can reduce inflammation and aids healing and reduces free radicals. So this gentleman was on immunotherapy, and he had quite severe mucositis, so ulcers in his mouth, and his mouth opening was really restricted. And this treatment he was coming in 3 times a week for, felt it was the only way he could get through the treatment, which this is amazing technology, which I think in the UK we're still researching, but I think there's a future for it, which we will, and that's the device there, we'll discuss with our oncologists. We also got to meet patients. It was wonderful. You know, we went up to the chemo unit. We met patients in clinics and discussed different ways that we support them, shared ideas. And we also got to interview this wonderful gentleman who just said, you know, the thing that I took away from his, he said, think about the edges of the system. You know, you've got your treatment, you've got your team, but think about what's on the periphery. Think about, you know, the patient outside that hospital. And I think that's why these support groups are so important. And he thought that this would be a support group, would be something he would definitely go to if it was to be put together. And, you know, he said it's going to be different when you're done. Of course it is, you know, but I think these support groups help patients and their caregivers lifelong. You know, we say goodbye to them at 5 years, which is great because they've been discharged from their cancer follow-up, but then they've got to live their life, and some people really need that support, and that's what the Swallows charity provide. I know we're pushed for time, so I just popped a little picture on there as well, because Arthur was very kindly took us into the theatre for the day as well, so that was absolutely amazing. We saw some really amazing surgeries, and this, again, the team were just wonderful. We got to meet the patients before and afterwards. So what I want to say is the Swallows also do their international conferences. So this year their conference is back in person and it's in Sunderland. It's 2 days and it's free. It's free to healthcare professionals, patients, caregivers. There are, it's funded by different companies, so there's lots of different stands for patients to and healthcare professionals to talk to. Really, really, really good educational event. So I'd love it if you could share that. It's also going to be online. So if you went on the Swallows website, you can link into the online conference, and it's going to be on recorded on YouTube. And even more exciting is it's coming to Torbay next year. So everybody in the Southwest, please promote the Swallows charities. Find out if you have a local Swallows head and neck cancer support group. Signpost your patients, their caregivers to these groups. Anyone in Torbay who knows of anybody, please let them know when our group is. And come to the conference next year. You know, it's going to be an amazing event, and it's free, and it's very rare that we get educational conferences for free. So I would love to see you there or online. So thank you for your time.
Thank you, Sam. I was really looking forward to hearing about it. It sounds like it was an absolutely amazing trip. So
it was, thank you. It was I wish I could, it's hard to put it all together in 10 minutes. I hope I sort of pulled out the, you know, the main points. If anybody wants to hear any more, because we learnt so much, I would love to share it. So if anybody wants to contact me, it's not a problem at all.
pop your email address in the chat if that would be okay. So I'm
Yeah, I'll
just in
do
the
that.
interest of time, we haven't got a lot of time for questions
Sorry.
at the moment. No, it was absolutely lovely to hear about it. But perhaps you pop your email in the chat, then if anyone wants to contact them, they can. So thank you, Sam. That was absolutely brilliant. We've been joined by Jane Milligan, who is the Chief Exec of NHS Devon. Hi, Jane. Thank you so much for joining us. I don't know if you wanted to say a few words.
Well, I don't want to get in under the feet of everybody. I just want to say, well, thank you actually to everybody, because I know this is, well, since I've been in the patch and in my job, this is the second week of this, and I know this doesn't happen just by sort of a magic. It happens by lots of people pulling together and putting a lot of time and effort into developing the presentations as well as the programme, and also I had the pleasure of attending. I didn't manage to stay for it all because I got dragged away to talk about ambulance waits, but the sort of AHP leaders strategy day a few weeks ago. So and again, you know, just want to say that from my perspective, as a AHP fellow AHP, but actually also working with Caroline and others in terms of how we continue to support the work of the AHP forum. So it's really very much you know, the key thing is, you know, events like this is a fantastic opportunity to do that showcasing of work and sharing. And in fact, yesterday I was at the sort of, with the great and the good, all of the chief execs across England, Amanda Pritchard, and, you know, the whole lot cadoodle, and the whole focus was about adopt and adapt. So about improvement work and how to share good practice. You know, this obviously plays very much into that. And the other thing just to say to Sam is, in fact, in a week tomorrow, I am going to Boston as part of a leadership course I'm on to do some work with a number of the hospitals there to look at some of the processes and the approach that they take. And as you say, it's good to go and see how other places do it. Sometimes it shows you that what you're already doing is pretty good, but actually it is really you know, important to be able to look outside of Devon, and you don't necessarily need to go all the way to Boston, but to look at how we can pinch with pride. And then on a personal level, I've got a member of my family who's just been diagnosed with some of the head and neck cancer. So I've already written down that the swallows. I hadn't come across the swallows before, so I'll be investigating that. But yeah, just it was more just to say thank you, and to, you know, to say I really do appreciate all the amazing work colleagues do in this space. And, you know, we shouldn't just be spending 1 year of the week celebrating, or even one day. Obviously it's National AHP Day today, which my mission is to celebrate it every day. So an opportunity to say thanks to everybody. So that was all, Abby.
Thank you so much. I think we agree as well. We've seen so much amazing work that's being done this past week, and I think we need to work out a way that we can share it more often rather than just once a year, because it's amazing to hear it once a year, but we need to hear it more, and there's probably a lot more stuff that's going on as well. So we're thinking about how we can best do that. So, but thank you, lovely to see you, Jane. Thank you so much for joining us. Really appreciate it.
Fantastic, and I'm going to stay for a bit longer if I may. So
yeah, no, absolutely lovely to. And all the sessions we've done have been recorded and uploaded to YouTube for everybody. So if anyone wants to see them, then I'll pop the link on. So we're going to hand over now to Becky. Becky, you are concluding our AHP week, so I will hand over to you if that's okay.
Thank you. Share my screen. Oh, okay, and I want. Sorry, it's not doing what I wanted it to do. I'm going to come out of it. Sorry, I'm going to come out of it. Okay, can you see my screen?
Not sharing quite yet. If there's any problems, I can always share it on mine, and you can just.
Hopefully, it will be now. You there?
Yes, looks lovely.
Yes, wonderful. Okay, so hello, my name is Becky, and I am a research radiographer and diagnostic radiographer specialising in CT scanning at Torbay. I'm also the research coordinator, and I've just finished my research associateship funded by the Clinical Research Network, and I'm going to talk to you today about my mixed roles and what they have brought to the radiology department at Torbay. So I'll talk about my diagnostic radiographer role, my research associateship, and my research radiographer and coordinator role. So I started at Torbay in 2004 as a radiology support worker. Before that, I'd had many other jobs, nothing in healthcare, but I'd had extensive experience in customer service. My support worker role gave me my first taste of healthcare and diagnostic imaging, rotating through all the imaging modalities. After 5 years as a support worker, I successfully applied for a fully funded secondment to undertake a BSc in medical imaging at Exeter Uni. After completing that in 2012, I came back to Torbay as a plain film radiographer. In 2015, I was promoted to CT radiographer in the CT department at Torbay, where I still work clinically now. My role in CT involves diagnostic imaging for patients for the purposes of identifying acute or chronic medical issues. I perform scans on heads and hearts, heads and bodies and bowels, from the top of your head to the tips of your toes. It's a very interesting job and is much more than just whacking a patient on the scanner and taking some pictures. I perform CT cardiac angiography here on the left and virtual CT colonography on the right. I perform angiograms of the head and neck, the lower body and the limbs. We also scan for the detection or progression or remission of cancers. So it's obviously, I love my job in CT, but after being there for 5 years, I felt it was time to do more, and I felt that I could do more. So when the post of 70 at 70 Research Associate was advertised, offering a secondment for 1 day a week for 12 months, I jumped at it. The post was split into 3, 1/3 experience of clinical research, 1/3 academic, and a final third focused on service improvement projects. I was also provided with a clinical supervisor in Catherine Bamforth and academic mentor in Mary Hickson. I was also given an honorary research associateship with Plymouth University. During my 70 at 70 research associateship, I successfully applied for the Clinical Research Network Research Associateship secondment, which is another 12-month award that allowed me a day and a half a week to continue building on the experience and tasks of the first Research Associate Award. My clinical research experience began with cardiology within the Cardiology Research Department, supporting delivery of the Senorita, Vesalius, Orion 4 and Select Life trials. My experience began by just watching and learning from the very experienced team there, but when Target trial began, I was able to play a much more active role, as it involved patients being randomized to either the current standard of care or to have a CT cardiac angiogram. My position as CT radiographer has been influential in study setup and the smooth operating of the delivery of the trial and the booking and scanning of patients enrolled and randomized to have CT scans. And then came MIDI study. It's a study from King's College London asking for anonymized MRI head scans to build AI reporting software that will prioritize and provisionally report MRI heads. This was my big opportunity to really take my position and move it to the next level. I am principal investigator for MIDI study, meaning I'm responsible for the setup, delivery, and ensuring we are operating to the protocol set out by King's College London. Last month, we were the 3rd top recruiter of patients to MIDI study of any site in the UK. We successfully enrolled 78 patients. And this was only possible with the support of the radiographers and radiology support workers in MRI and the research nurses and the research team and research coordinators who are modelling great practice and nurturing my colleagues in MRI so that they can feel more confident and able to enrol patients without the research team support, building an ethos of research being part of our day-to-day business and something that should be embedded within radiology. My academic achievements, I've completed a PG cert in CT scanning at UWE. I've finished 2 master's level modules at Exeter Uni in implementation science and health economics. I've done a short course with Imperial College on researcher development and the NIHR Learn training on good clinical practice and informed consent training. I've also had 2 abstract submissions approved for poster presentations at the Torbay Clinical School Conference in 2021 and at the European Conference of Radiology in Vienna. So my service improvement projects. We are in the final stages of finalising a rapid access pathway to CT for patients with suspected upper GI cancer, and this will allow a small group of patients that would benefit enormously from diagnostic imaging to receive a CT scan within 72 hours of identification, and this will guide surgical or interventional treatment or palliative care. This has involved collaborative working between Luke Summers, consultant gastroenterologist and hepatologist at Torbay, and the gastroenterology specialist radiologists. We can now offer in-house portacath attachments for the administration of the iodinated contrast we use in CT. This means our patients with portacath no longer have to go to Ricky Grant for attachment and then down to CT for their scan before going back up to Ricky Grant to have the attachment removed. So this came after a very heartfelt letter from a patient asking for improvement. Well, we've done it. And again, involving collaborative working with Lee Merry and Rachel Andrews from the Vascular Access team, and Louise Carthew and the other radiology nurses here at Torbay. We now have a pathway for patients with renal impairment. It's in place and it sees patients no longer waiting for extended periods of time for communication with referrers and blood tests. The pathway outlines a clear procedure to ensure a patient's renal impairment no longer impedes timely diagnostic imaging. So this was designed after discussions with Mark Gilchrist, consultant nephrologist, and Dr. Higgins, the consultant radiologist, and all the radiology secretaries and call centre. We are now using the Braun Intracan Safety 3 cannulas in radiology, and they allow a faster flow rate of contrast through a smaller bore cannula. This is especially effective when cannulating patients with poor vascular access, requiring IV iodinated contrast as part of the scan, and it's reduced the need for multiple attempts at cannulation. I have completed audits of our CT KUBs and C-spines, which have both shown areas of improvement that can be made and have been made to reduce radiation dose to patients without reducing image quality. And I'm a bit sad, and I love a spreadsheet. So I designed spreadsheets for the recording of our daily QA tests on the CT scanners using complex equations and the use of and if statements. This was previously recorded on paper, but is now completely digital. I also did the initial data collection for our change from an on-call system to a shift system. I found that during our 12-hour on-calls, we were claiming for around 60% of that time. And this was after having already done a 7.5-hour day. So thankfully, my input was only in the early phases as some of my colleagues took over. So my research coordinator role, I am a key contact for communication between radiology and the research department. I review research trials and setup. I ensure imaging reports and the actual scan themselves for patients enrolled on trials are performed in a time window that's designated. I connect with the various research teams. I support research and research activity and ensure research involved medical imaging meets the appropriate ethical and governance criteria. So my next steps are to build on my service improvement projects with a focus on education, development and research in the department through the implementation of regular CPD sessions, further audit and quality improvement projects, as well as signposting papers in journals for discussion, and move towards further embedding of EBP being at the forefront of how we work, not only in the technical aspect, but also exploring patient and public involvement. I'd further like to explore advanced practice, and I've just accepted a lecture practitioner role in medical imaging at the University of Exeter. I will also be submitting abstracts for poster presentations, a PCAF application, and doing more networking and collaboration. If anyone's interested, obviously you're welcome to contact me for further information on anything I've done or with any further ideas for collaboration. And that's all. Thank you. Any questions?
Wow, thanks, Becky. You've been very busy.
Sorry, that's a lot there.
That's an amazing amount of work you've been up to.
Thank you.
Has anyone got any questions for Becky? Or we've got a few minutes. If anyone's got any questions for any of the presenters, then please feel free to pop your hand up or pop something in the chat. Rin.
Hi Becky, thanks for that great presentation. I just wondered if you had any advice for anybody at the very start of their research journey, and what inspired you to take that first step, and what stimulated your initial interest?
My advice for people interested would be to speak to the research team if in your local hospital. At Torbay, we have a great team in Catherine Bamforth and Richard Collings, and then we
I haven't paid you to say that, by the way.
Well, yeah. There's also the cafe, which is the Clinical Academic Forum and Exchange that meets regularly, and you can get dates for that. There's lots of people at Torbay who are very keen to support and very active, and who will encourage and nurture and to help make sure that you progress if that's what you want to do, or just with small projects. What was the second part? Sorry, Catherine.
What made you interested in research in the very first place? What made you take that first step to finding out more about the 70 Associateship?
So it was during COVID, and I was sat on, we call them the elephant's foot, you know, those little footstools, looking around, and we were recycling the same practice over and over again. And I felt there's more. I feel like we can do more. There's people are doing research all the time. Why are we not updating our practice? What are other trusts doing that we can do better? Where can we see good practice, better practice? It felt at that time, sat on that stool, that we weren't moving forwards and we were just recycling. And that's what's motivated me, is to keep the momentum moving, to improve and adapt, I think Jane said, and progress, and not just, we can be so much more. Well, once we've done our degrees, at the moment clinical pressure is taking priority, but there should be more to it. There's more to our world, and there's people who are keen out there to share and disseminate information. What's the point in doing all this research and great work if we don't share it with other teams?
Great question and great answer. Really good answer. We've got probably time for one more question if anyone else has got the question. I'm not seeing anything, any hands or anything in the chat. So I don't know if people want to pop, the presenters want to pop their email addresses in the chat if they haven't done already, so people can always contact you directly if they've got any further questions. Other than that, I think probably we'll wrap up and say a massive thank you to everyone this week. So we've had lots of different people chairing, lots of different presenters. It's been a brilliant week. I think we've just really shown, we know what brilliant AHPs we've got in Devon, but I think this week's really shown it, which has been absolutely brilliant. All of the webinars are going to be put up on the Devon AHP faculty YouTube page. So if you want to have a look back at the week's one, they take a little while to upload, so it'll probably be over the weekend they actually become accessible, but please feel free to have a little look at those. Any problems accessing, I think if people have had a problem accessing them, just drop me an email if there's a problem and I can help you access them. Other than that, just for me, really a massive thank you for everyone engaging. We've had loads of people coming each day. It's been really, really lovely. Yeah, and a massive thank you. Have a lovely weekend when it arrives. Take care.